Over the past 2 years, doctors have performed thousands of successful small incision surgeries. With each procedure, doctors continue to refine and perfect the techniques for creating a 3-plane, self-sealing incision. In this video presentation, we will go beyond the basics of creating a watertight, small incision wound to explore how subtle procedural improvements and product enhancements are helping doctors perfect every step of small incision surgery. We'll begin with the initial groove incision. Ideally, the groove incision is created with a smaller-nosed, rounded cutting instrument similar to the 57 blade shown here. Normally, the groove is located parallel to the limbus at a distance of 2 millimeters from the limbal line, though preferences for optimal shape and location of the initial incision vary from surgeon to surgeon. Groove depth is normally 1/2 scleral thickness, or approximately 1/3 of a millimeter. Incision width should correspond to the width of the IOL to be implanted. Since different surgeons prefer different incision sites and shapes, most use a rounded freehand type blade, like the 57. Though knives with preset guards and depth gauges are available, many surgeons prefer to judge the depth of the incision by feel, since scleral thickness can vary from patient to patient. Also, the 57 eliminates the danger posed by the extremely sharp edges of diamond or gem knives, which could cause problems if the blade passes too deeply within the sclera into the choroid. Many surgeons now create a small lip or shelf at the base of the groove incision, as shown here. This initial lip greatly assists in the next incision step, the scleral tunnel incision. The groove incision completed, an extended, rounded knife is used to create the 1/2 depth tunnel incision. The length of the tunnel usually travels from the initial incision site up to the limbus at the vascular arcade. When forming the scleral tunnel, the knife should stop just as the knife tip appears in clear cornea. The crescent knife, or the disc knife, is commonly used to create the scleral tunnel. The crescent knife has an elongated 180-degree cutting surface, which is passed through tissue with a side-to-side and forward and back motion. The design gives the surgeon excellent accessibility and control in creating a tunnel, regardless of the tunnel's shape or length. However, for those who prefer to create a larger internal flap, the disc knife may be preferred. The disc knife has a shorter 270-degree radius cutting surface and passes through tissue using a rocking motion. This design is best for surgeons who require an internal tunnel with a greater width than the initial groove incision. The broad radius cutting surface simplifies a back cutting function, which helps to create a wider internal flap. However, there are some drawbacks to the design of the disc knife. The rounded broad cutting surface can be hard to control, and the reduced blade length limits accessibility to the limbus and vascular arcade in longer tunnels. Tunnel depth should be gauged by observing the outline of the knife through scleral tissue. Ensuring that the tunnel is not too deep or too shallow avoids complications, such as severing the choroid or buttonholing up through sclera prior to entry into the vascular arcade. The location of the bevel, or raised portion of the blade, plays an important function in creating a consistent half-depth incision. The knife's bevel creates a specific knife motion, depending on whether the bevel is on the anterior surface, bevel up, or posterior surface, bevel down. Generally, as the blade is passed through tissue, the knife is forced to the direction opposite of the blade's bevel. With a bevel up blade, the knife tends to pass slightly toward sharp. A knife that is only marginally sharp can result in an irregular shaped valve which may not seal. In addition, entering the anterior chamber with a dull knife increases the potential for stripping Descemet's membrane, causing endothelial problems for the patient and decreasing visibility for the surgeon. The refined small incision techniques described here help to lessen induced postoperative astigmatism and improve patient healing. However, these techniques can occasionally create their own challenges during phacoemulsification. First, there are the physics of advancing the phaco probe through a 3-plane incision versus a single-plane incision. Occasionally, a small 3-plane incision will decrease range of motion of the probe or crimp the irrigation sleeve. This may cause a decrease in irrigation flow, raising the potential for corneal burns. Using a wider slit knife can eliminate this problem. For most phaco probes, a 3.2 millimeter slit knife is preferable, both to provide an incision wide enough for easy passage of the probe and to allow for adequate irrigation. Smaller incisions also increase the difficulty of accessing and manipulating the nucleus. For this reason, hydrodissection now plays an important role in optimal small incision surgery. Newly designed cannulas with blunted, flattened ports facilitate injecting BSS into the fornices of the capsular bag. By assisting separation from the epinucleus, this step allows the nucleus to rotate for easier and faster phacosurgery. Some techniques result in separation of the cortex and epinucleus as well, reducing the amount of cortical cleanup following phacoemulsification. Another popular technique for accessing and manipulating the nucleus is the paracentesis, or side port incision. This technique permits access to the cataract with a second instrument. As shown here, the incision is typically made at the 2 to 3 o'clock position using a 15-degree blade. After phacoemulsification, the final step in small incision surgery is to prepare the wound for implantation of the intraocular lens. To assist with implantation, many surgeons now use an implant knife specifically designed to enlarge the wound for the IOL. The shortcut knife, shown here, is advanced through the 3-plane incision, enlarging it to the appropriate width for a 5 by 6 millimeter optic IOL. There are many advantages to using an implant knife. First, an implant knife reduces the sawing of tissue in order to enlarge the wound. The result is better tissue apposition for improved astigmatic control and faster patient healing. Second, enlarging the wound with an implant knife preserves the integrity of the self-sealing incision. The knife enlarges the wound in the same plane, keeping the internal corneal valve intact for a watertight wound. Finally, an implant knife provides an exact incision width for the IOL being implanted. This eliminates any guesswork on implant incision size, keeping the incision optimally small. The implant blade chosen should have a non-cutting rounded tip and a short length from the tip to its widest point. These features, illustrated by the shortcut knife, minimize the potential of puncturing the posterior capsule or nicking the opposite side of the iris, two complications experienced occasionally with first-generation implant knives. As more and more small incision surgeries are performed, doctors continue to refine their techniques for creating the optimal wound architecture. Though successful small incision and self-sealing surgery pose challenges, the continued introduction of refined incision techniques and innovative new products will help doctors master these procedures. By ensuring that the groove, tunnel, phacostab, and implant incisions are optimally created, the many successes of small incision cataract surgery will continue to grow.